Frankie, I say about recording. Okay. So hi, everyone. I'm Paula Tavro. I'm the director of the Bixby program here at UCLA's Fielding School of Public Health. And it is really my pleasure to introduce to you all today Jennifer Erausquin. She is an associate professor in the Department of Public Health Education at the University of North Carolina, Greensboro. She is an expert in sampling hard-to-reach populations and in developing survey measures for sensitive topics and behaviors. She's a proud UCLA Fielding School alumna. She received her MPH in 2004, her PhD in 2008 in our department, Community Health Sciences. And together with some other alums, one who unfortunately is deceased, she co-edited a book entitled Global Perspectives on Women's Reproductive and Sexual Health Across the Life Course. So I now will turn it over to Dr. Erausquin, and I do ask that if you can to hold your questions for the end. We'll have about 10 to 12 minutes for Q&A. Thank you.
Good afternoon, everyone. I'm very excited to be here and to be able to share some of my work with you. All right, can I get a thumbs up if that's showing correctly? All right, very good. So today I'm going to present some descriptive results of our study, which is a mixed method rapid epidemiological assessment of the health of migrants in transit at a migrant reception station in the province of Darién, Panama. And first of all, I want to acknowledge and praise the multinational team who carried out this complex and innovative study. Migration is a big issue in the United States today. There is now daily coverage of the situation at the US-Mexico border, where thousands of people are awaiting their chance to enter the United States. Due to the application of a policy known as Title 42, which was applied during the COVID-19 epidemic as a public health means to restrict nearly all entries at the US-Mexico border, there are thousands of people waiting in migrant camps. I'm sure you've seen images from Tijuana, Ciudad Juarez, and in numerous other points. But how often do we think about how it is that migrants get to the US-Mexico border? What did their journey involve? For an ever-growing portion of migrants from all over the globe heading to the US and Canada, their path involves a dangerous trek through Colombia and Panama. It's the experience of these migrant peoples that I'm going to talk about today. So here we are at the Panama-Colombia border. And this is zooming in there at the border. And here I'll point out a couple of different features. The yellow lines on this map show the Pan American Highway. The Pan American Highway is a system of roads that connects all of North, Central, and South America from Alaska to the southern tip of Argentina, except for a 66-mile gap between Colombia and Panama. That gap, which is in the middle of the Darién forest, is often called the Darién Gap. Migrants seeking to move from South America headed north have no choice but to travel through that area on foot. It's a roadless stretch of mountainous rainforest. There are no plans to build a road here. Mountains and dense jungle make the landscape too hostile for infrastructure, or so the argument goes. There's also 1.4 million acres of UNESCO protected national park here. It's a little bit hard to distinguish the Colombia-Panama border here. It's a little bit to the right of the marking for Cerro Tacaracuna. And you will see, let's see, on the Colombian side, the farthest west, that the yellow line, again, that's the Pan American Highway. The farthest west that it goes is Necoclí. And on the Panamanian side, it continues beginning, well, depending on where the migrants catch it, but near Yavisa. Here we have Nicoclí, Organa, and Acandí again on the Colombian side. They're separated by the Gulf of Urabá, and that can be traversed by boat. But again, the migrants are trying to reach the continuation of the Pan American Highway in order to continue their journey north. A recent piece presented in print and video from CNN focused on migrants' trek through the Darién Gap. And this is an image from that. There's a few different paths to take depending on how much money somebody is willing or able to spend. Most routes involve some boat travel on rivers, but typically at least 5 days on foot, where folks will be crossing rivers, pulling themselves, their belongings, and often their children up steep mountainous and muddy terrain. There's deep mud everywhere. Again, this is from this is the route that the CNN journalist took. There's a couple of different routes. This route, I believe, is the one that involves climbing the Cerro de la Muerte, the Hill of Death, to reach Panama. And as you can see from the map, reaching the border between Panama and Colombia is by no means the end of the journey. When migrants make it there, they still have probably 2 or 3 days more. And then when migrants exit the Darién forest, they're intercepted by Panamanian authorities and taken to a migrant reception station, which sometimes in my presentation I abbreviate as ERM for its letters in Spanish. At a migrant reception station, as I'll get into in just a minute, every single person is officially registered. The journey through the Darién Gap was described recently by one NGO as a lush green hell. Many who survived the Darién Gap say they wish they hadn't tried it. Their experiences are going to stay with them the rest of their lives. Not infrequently, they witness death, family members, strangers, and those who must be left along the side of the trail. We keep these experiences in the context of understanding what the process of international migration is like more broadly. International migration can be physically difficult, dangerous, and chaotic. During transit, the health needs of migrant peoples, and in particular their sexual and reproductive health needs, grow because they're facing conditions and vulnerabilities for which they're not prepared. The migration process often disrupts familial and supportive social structures and can involve a really dramatic loss of financial means of support and security provided by family and friends. It also often involves the disintegration of law and order. Of what we know about the Darién Gap comes from journalists, like the CNN story I mentioned before, this piece in the New York Times. There's also reports from aid organizations like Doctors Without Borders. And the journalists' reports are growing and growing. Might be surprised to find that that it's really global migration that occurs through this small, again, 66-mile long pathways through the jungle. In a pilot study that assessment that we did, our team did, countries of origin of adults are marked here. They included clearly folks from Latin America and the Caribbean, but also folks from West, East, and Central Africa, as well as Asia. And so you might think, well, why or how are they doing that? So it is not uncommon for folks to take air travel to a location in South America where visa requirements allow them to enter. Maybe Brazil, maybe other South American locations, and then begin their journey north. And sometimes there's a gap or a time spent in an intermediate country for a period of months or a period of years. before they continue their journey north. And so, for example, it was 2016 in which Hurricane Matthew hit Haiti very hard. At that time, a lot of Haitians traveled to Brazil and to Chile. In 2021, following border openings after as we were coming out of the first wave of the pandemic, those Haitian migrants in Chile and Brazil started moving north. So the International Organization for Migration and the National Migration Service of Panama estimated that in the first 9 months of 2021, about 91,000 migrants transited through the Darién forest. And that number was about triple the previous highest annual count, which was 30,000 in the entire year of 2016. In February and March 2022, an approximate average of 5,000 migrants transited through the Darién forest. That number is now multiplied by at least 4. In Panama, as I had mentioned before, migrants who emerge from the Darién forest are received by the National Border Police, known as Front. They're taken to migrant reception stations. And these migrant reception stations are part of a coordinated effort between the United States and Panama to control the flow of migrants. With the help of US tools, training, and technology, biometric measurements are taken of all migrants in the MRS to identify suspected terrorists and maintain documentation of people who are migrating. And then the length of stay that the migrants have, their length of stay in the migrant reception stations, varies according to their nationality, their demographic characteristics, and individual needs. It might be a few days for citizens of countries with expedited processes. So right now, Cuba and Haiti have expedited processes, and it could be several weeks or months. It may feel like a big success for the migrant folks to reach a migrant reception station, but their journey involves a lot more money and other resources that they might not have anticipated. So in order to continue their journey on through Panama and onto Costa Rica, they have to have money for a bus ticket that would leave the migrant reception station and allow them to continue on. And this infographic, I like it for, as another map with another level of detail. It shows the initial boat trips that usually happen from Necoclí in that region. It shows 3 routes out there in orange. It also, now this is from July 2022, it shows that at that point, 1,500 to 1,600 migrant people a day were arriving on the Colombian side in Necoclí, and 1,400 people a day were arriving in Panama's migrant reception stations. And the font on this is really small, but this is part of setting up the logic for our study. So there have been a couple of smaller scale analyses of healthcare access done either by IOM or with assistance of these other organizations, the Red Cross and Doctors Without Borders. But both of the 2 assessments, the one done in Lajas Blancas and the one done at San Vicente, did not address health. They addressed other needs, but not health. So the Pan American Health Organization has a list of priority actions in terms of strengthening surveillance and monitoring of health conditions. And they particularly call out the need for comprehensive profiles of the health status of migrants, and a need to strengthen national and decentralized health surveillance systems, especially in border transit areas. And so our study aimed to assess migrant people's health status needs and the impact on surrounding communities, as well as look for opportunities where service provision could be created or improved. And in terms of sexual and reproductive health, our aim was to describe the sexual and reproductive health of migrant people who are still in transit and to identify targets for intervention. So overall, the study was set up with a qualitative component and a quantitative component. Today, I'm going to mostly be talking about the quantitative component. The qualitative component did involve interviews with members of national and international organizations who are stakeholders in migration, folks from the Ministry of Health, people living in communities impacted by migrant transit, as well as in-depth interviews with migrant people in transit themselves. On the quantitative side, we had, and I'll get into this in the details in just a minute, we had multiple components or aspects to it. Many of the pieces of information came from a self-applied questionnaire. We also assessed their mental health, their sexual and reproductive health through a clinical visit, general and tropical medicine also through a clinical visit, and a nutritional assessment. So the photo that you see there is from the migrant, is a photo of the migrant reception station where we did our data collection in January 2022. And the graphic shows countries of origin of the folks, all the folks who entered the migrant reception station and participants in our study. So the lighter blue is folks who are participant in our study. So we did a pretty good job in reaching proportional participants. You know, you can see that many come from Venezuela, from Haiti, from Cuba. There were many folks present from Senegal, but due to the language requirements, so that we only had our study was only available in 5 languages. And so many of the folks from Senegal had language barriers there and could not participate if they were recruited. So this table shows some of our inclusion criteria. So for the qualitative component, everyone had to be over age 17. Same was true for the self-administered questionnaire. For mental health and sexual and reproductive health clinical components, folks needed to be over age 11. And then for general and tropical medicine and nutrition, we did include all ages. And the other, I had mentioned the languages, Spanish, English, Haitian Creole, French, and Portuguese. The other piece of exclusion criteria was if they were going to leave very quickly, they arrived at the migrant reception station and were going to leave that same afternoon, for example, that probably wouldn't have given us enough time for them to complete all the components of the study. And so those folks weren't eligible to participate. And so taking just a step back for a moment, all of these pieces of information, sort of how are they fitting together and why are we doing this? We've covered. There's been an increase in the number of migrants, particularly those passing through the Darién forest. The health needs of migrants in transit probably grow, but there's not existing data to show what those needs are. And the circumstances of migration inhibit access to sexual and reproductive health services, but also at the same time may increase their need or their vulnerability to things like sexual violence, coercion and exploitation, transactional or survival sex, sexually transmitted infectious and unwanted pregnancies. Here's our objective, and again, more photos from that particular migrant reception station. And so this was, as I had mentioned, the rapid epidemiological assessment done as a cross-sectional survey or study. We did randomly select participants And I'll show you in a minute how we did that, because people were usually traveling in groups. We did data collection between January 4th and 11th of 2022. And folks could participate in 1, 2, or 3 of the components, depending on what they were willing to do. So the self-administered questionnaire, clinical screening, and HCG, syphilis, and HIV testing. And I'm going to present some of the descriptive analyses. So this is a picture of one of our MPH students involved in the project, doing some random selection of participants. Folks were often traveling together in groups, and we didn't want to select people only from the same family group or traveling group, because they would be more likely to have similar characteristics. And so when there was a group of folks traveling together, we would do a process where somebody was randomly selected from that group to participate. Everybody was given informed consent and explained in a language that they could understand. They completed a self-administered, after receiving the informed consent and assent for the younger kids, the participants 17 and older, older than 17, self-administered a questionnaire on a tablet, and participants gave blood, mid-flow urine samples, and participated in the clinical examination. And folks needed assistance, either because their attention was somewhat occupied, often by a young child, or for literacy reasons, we administered the questionnaire to the folks. And this is a picture of folks from our field laboratory, hard at work doing the blood collection there. And we set up private areas where our physicians and other healthcare providers could work to do the different aspects of clinical assessment. Participants were offered test results and appropriate treatment according to national guidelines within 3 hours of enrollment in the study. And all participants were offered a meeting with a psychologist and a psychiatrist. So this was a big study, so we have lots of results. Today, I'm going to focus on sexual behavior, perceptions of safety, and history of sexual victimization, as well as pregnancy. So in terms of who we had participating in the study, in total, 69 men and 55 women were included in the self-administered questionnaire, 70 men and 51 women in the clinical screening, and 78 men and 63 women for the urine and or blood tests for HCG, HIV, and syphilis. The median age was 31 years for men and 30 years for women. There was educational level variation by gender, where most women had no formal education, at about 53% of women, while most men had attended primary school in grades 1 through 6. So it's also about 50% of men. Region of origin of the participants was mostly North or South America for 50% of the men and 35% of women, the Caribbean for 13% of men and 53% of the women. So a lot of women from the Caribbean. We had a small number of men from Asia, ending up about 6% of our sample. And we had folks from sub-Saharan Africa making up 30% of the men's sample and 13% of the women. And this graphic here shows some of the reasons that they gave us, their main motivation for why they were doing this trek, why were they migrating. And there were differences between men and women, but largely centered on war or conflict, avoiding war or conflict, avoiding other type of violence, work and family reasons. Most of the men, 62% of the men in our study were single, divorced, or widowed, whereas more than 2/3 of women were married or living with a partner at the time of their journey. A total of 26% of men and 36% of women reporting having had sexual relations in the last month. And of these, among men, 50% reported having one sexual partner, 44% three sexual partners. Among women, 90% reported one sexual partner and 10% three sexual partners. It was reported that the last sexual partner was casual among 43% of men and 28% of women. And that last sexual partner then was formal for 57% of men and 72% of women. So women more likely to have their last sexual partner be a formal partner. 43% of men and 80% of women reported not using a condom with their last casual or occasional partner. In terms of HIV tests, 58% of women and 6% of men. Actually, I'm going to talk a little bit about reproductive tract infections first. So 59% of women and 6% of men reported a current symptom of reproductive tract infection. A total of 33% of men and 18% of women reported that they had never had an HIV test prior to this study. And of the 78 men who were tested, HIV and syphilis were found in between 1.3 and 2.6% of the men. And so I believe that was 1.3% or one case of HIV found in 2 cases of syphilis. And then among 63 women tested, we had 2 cases of HIV and 2 cases of syphilis. Also, in terms of reporting on lifetime experience of rape or sexual assault, and this is self-report coming from our self-administered questionnaire, 9.2% of men and 13% of women reported having experienced that in their lifetime. However, the majority of those, so more than half of men and 2/3 of women, reported that the rape or sexual assault had occurred in their country of origin. So at least according to what they're telling us, this was not a recent experience that had happened during their travels. And we think that this is still important and something to think about because of the ripple effects and the mental health implications of having experienced rape or sexual assault. We also asked folks a question about how safe they feel from sexual assault in their daily lives or their everyday lives. We asked it referring to before leaving their last country of residence, since leaving the last country of residence, and since arriving in Panama. So the last time that they were sort of stable in one place, during transit, and since arriving in Panama. And the response options are listed there in red. And just for the response option, not at all safe. So folks who feel not at all safe. Really with, for men across the board, in terms of the 3 different contexts, 27% are reporting that they feel not at all safe from sexual assault. In terms of the women's results, there was some variation by context. 29% felt not at all safe before leaving their country of residence. That went up to nearly 40% since leaving their last country of residence. And then since arriving in Panama, which for some would have been only a matter of days, 36% felt not at all safe from sexual assault. In terms of pregnancy history and current pregnancy, this shows some of our main results. We asked both men and women about lifetime pregnancies. And so clearly for men, we're asking how many times have you gotten a woman pregnant? And so that's listed there. For most women, the age of their first pregnancy was somewhere between 18 and 30 years. Although, 24% are saying that their first pregnancy occurred before they were age 18. We asked them whether they were currently pregnant. 9 women reported that they were. Our clinical assessment found 2 additional women who were pregnant. So there were 11 pregnant women in our study. There were folks in their first, second, and third trimester in our study. And that was also remarkable. So 20%, 11 out of 55 of women had tested positive for pregnancy, and 5 of those 11 pregnancies were planned. There are a number of, I think, takeaway points from our study, which again was a rapid assessment. It's intended to be the first look at the health status of migrants in transit who have exited the Darién forest. Our findings are telling us that migrants in transit through the Darién forest are in great need of STI testing and treatment and other access to sexual and reproductive health care. Our findings suggest a high prevalence of recent sexual activity. The risk of STI acquisition was high because a large proportion of migrants indicated that their last sexual partner had been casual and without a condom. Among women, we found that 1/5 were pregnant. HIV seroprevalence was 1.3% for men and 3.2% of women. 2.6% of men and 3.2% of women tested positive for syphilis. Among women, 40% reported vaginal discharge. Of those, a quarter tested positive for a number of different infections. More than a third tested positive for bacterial vaginosis. So our findings really indicate that migrants in transit in the Darién forest are in great need of access to sexual and reproductive health care. In terms of the recommendations and future research that is coming out of this study, we really feel that the interagency field manual on reproductive health in humanitarian settings, which the image of the 2018 version, the most recent version is up there. We think that that needs to be used as a guideline for how healthcare is provided, and that healthcare should be provided in the migrant reception stations or at some point that is accessible to migrants during their journey. There also needs to be gender-specific care, specifically, especially for women and girls and LGBTQ+ populations. Both cultural, social, and privacy concerns. That was something that our participants mentioned and valued about just the care that was provided to them as part of the study. Right, the care that was provided is not something regularly accessible to migrants at the migrant reception station. And in terms of next steps for research, there definitely needs to be follow-up research on sexual and reproductive health care and needs for diverse and changing populations. I had indicated that the migrant flows continue to increase through the Darién forest. And there's been some exciting steps taken in terms of follow-up research on sexual and reproductive health care. The PI of our study, Amanda Gabster, who's at Instituto Gorgas in Panama, had a student just a couple months ago who did some qualitative research at other sites outside of the migrant reception stations, but with migrants in transit, specifically focused on a deeper dive into their sexual and reproductive needs through the transit process. The other piece that we think really needs additional research and is probably the first step that is the actionable or the translational piece that's needed is around the mental health of migrant peoples in transit. We have a couple of papers in the works using the results of the mental health component of our study, but the experience of trauma that was reported among our participants was very high. And, not surprisingly, but something needs to be done to address that. So if you're interested in learning more, we have a number of publications that are already out. So we did publish our protocol prior to our data collection. That's available. I had published in the fall a first descriptive piece on the SRH results, and that's available in Frontiers in Reproductive Health. And we also have a commentary in Travel Medicine and Infectious Disease about the need for healthcare for migrants in transit, and really the responsibility that the U.S. and other countries that are along the migrant path, including countries that are further down the migrant pathway, really have in terms of ensuring the health and safety of migrant peoples while they're in transit. Like I said, migration through Darién continues every day. These are some shoes of folks who had exited the Darién forest. Lots of people to thank for my involvement in this. First and foremost, of course, the participants and the guardians of the minor participants who are involved in the study. There are no words to express my gratitude. Lots of people were involved in this study. I'm just going to list the organizations here. And funds and material donations were provided by a number of donors, including governmental, non-governmental, and pharmaceutical companies. And we had all kinds of tests and lab equipment donated, which was incredibly helpful. Oh, thank you for your time. I'm really looking forward to some good questions out of this.
So thank you so much for that really insightful presentation. And I think a lot of us, I know certainly I'm speaking for myself, this is news about that geography, and this whole Darién gap is brand new to me. Very troubling, some of your findings. So let's open it up to questions. People are welcome to just unmute and ask a question, or put up your hand, or put into chat. I will maybe start off and just ask you, I'm presuming that abortion services are not available to people. So like people who didn't even know they're pregnant or would want to be pregnant on this journey, do they have any options at all?
That's a good question. And my understanding is no, that they don't have abortion services available to them.
Mm-hmm. But do they have, what types of, like you were assessing like what was happening to them, but what are the services that they are offering them currently?
So currently there are no services in any of the trails that they would take to cover the 66-mile Darién gap. When they exit the Darién forest and are brought to a migrant reception station, there's the possibility that there is a basic health clinic, typically staffed at varying hours by volunteers from Doctors Without Borders. And that is not at all of the migrant reception stations. So this is just when Doctors Without Borders is available, when they can, and in certain, but not all, of the migrant reception stations. The Senafront, the immigration force in the immigration police in Panama will bring people who are in full crisis or a medical emergency to local healthcare providers. But that somebody would have to be very critical for that to occur. You can imagine, as I was describing the track, in terms of risks, we're talking about injuries from falls or overuse. We're talking about snake bites, other animals that may be present on the trail, allergic reactions to a number of plants. In addition to most of the routes used by migrants are used exclusively for the transport of human beings. Other routes, which are typically more hidden, are ones that would be used for trafficking of other things like drugs. But to the extent to which there is overlap between the human migration and the drug trafficking, those are points at which the gangs and human traffickers would be a bad combination, a dangerous one.
Thank you. Abigail.
Hi, thank you so much for your presentation. I wanted to introduce myself. My name is Abby. I have been spending the last 5 years working with refugees and asylum seekers in Costa Rica, just north. And many of the people that I encounter have been also through the Darién Gap. And I wanted to ask about two things. One, I wanted to echo the prior question about abortion services and just highlight a resource that I put in the chat. For women who might be interested, Women on Web provides free pills, including to countries, specifically to countries where abortion is illegal. And they do a consultation. They exist in international waters, which is how they do that. But I wanted to highlight that resource because something that similarly that comes up in my work in Costa Rica are extreme cases of postpartum depression with attempted suicides and things like that. Where women really become desperate from the combination of trauma that they have experienced and their current constraints that they face. One question I had was about the Ministry of Health in Panama and their interest also as a stakeholder in this population. Do they view this population as transient? Or do they view this population as still like a semi-permanent public health presence? And
yeah,
thinking about just like the spread of sexual STDs within their own country.
And the lead of the study, Dr. Gabster, is on this call, and so she may be able to expand on this a little bit. But it's my understanding that the Ministry of Health views these folks as in transit, as not a stakeholder group that they need to pay particular attention to. Panama is very clear. When you are processed at a migrant reception station, you are not authorized to stay in Panama. The migrant reception stations have a lovely, welcoming name. They are within chain link fences that are 12 to 16 feet tall with barbed wire at the top. People are instructed to stay inside the gates, and they are not authorized to be outside and to be freely moving. Their only authorization is to continue on and to continue to the migrant reception stations that are then on the Panamanian side of the border with Costa Rica, with the intention of, again, getting checked in, making sure everyone has been processed through, no one's been lost or left behind, and moved on to the next part of the route. Thank you very much for sharing that resource. That's fantastic too. Thanks, Abigail.
Yeah, sorry, just to follow up, I'm just curious. The reason I'm asking is because in Costa Rica, the Ministry of Health on the border with Panama in particular is concerned about the proliferation of STIs because of transactional sex. Mm-hmm. And my experience, I wonder, I'm guessing that in Panama it would be similar. the Ministry of Migration wants nothing to do with my research, but the Ministry of Health is quite interested. And so I'm wondering if you're experiencing something similar, and the extent to which the Ministry of Health is able to operate separately from the Ministry of Migration in Panama, given their vested interest in the public health of Panamanians.
Yeah, that I don't really have a sense of, though it's really interesting. So you may be aware earlier in April, it was announced that the US, Colombia, and Panama now are trying to implement a plan to end, as in to completely stop the flow of migration through the Darién forest. If they can't get a road through the Darién forest, how they're going to be able to completely block off human travel through that area is, you know, a little bit beyond my comprehension. But there seems to be lack of recognition that if you stop a flow, then there will be backup somewhere. So if we're stopping the flow at Darién, then there's going to be a backup in Colombia, right? That's what we would assume. And so the thinking through of what the result of some of these policy actions that are being proposed or implemented is really questionable. And I would agree that the Ministry of Health should take an approach of, if I care about the health of citizens and residents of my country, that would include the health of folks who are here, whose health then influences the health of folks around.
Thank you, Abby. Other questions? I actually do have a few more. Oh, I see there's one in the chat. Or Amanda's written, until they get to the border with Costa Rica, they are really in the camps and on buses, and there's not really any mixture with the Panamanian population. So interest is low, even though from the city of David, they might be participating in transactional sex. Oh, okay.
And I would like to just add that there have been some reports, particularly in the migrant reception station where we were doing data collection. In 2023, there's been an increase of reports of sexual assault happening in the migrant reception station and transactional sex, accusations of transactional sex between migrant women and men who are part of Centerfront, the immigration police.
So another question I had is about those people who are found to be HIV positive, and some may not even have known it. How are they getting on to antiretroviral treatments and staying on? I mean, what is the protocol there?
So there is a great resource that we were using in our study that is basically a map that has been created for the entire pathway from Panama to and through the US, where folks can access free or low cost HIV medications. So throughout their entire journey. Most of the, let's see, some of the people who tested positive with us did know that they were HIV positive. And I know of at least a couple that I interacted with had brought their HIV medications with them, and with a large enough supply that they were expecting to be able to get at least to Mexico. And Mexico has a pretty good network of ways of accessing HIV medications, even for migrants in transit.
And I think we're nearly out of time, but there was one last question, I think, from Paul. Did you have your hand up?
Sorry, can you hear me?
Yes.
This is a more general question, but I apologize if I missed it. Was there a sense, or did you happen to catch the proportion of migrants who were repeat going, back through again? I don't know if that's a relatively small population. I just asked this because obviously in light of Title 42 next week, I'm sure there's going to be an increase of people trying to come back or trying to travel through?
So that's a really interesting question. It's not something that we systematically asked folks. It did come up in conversations that I had with people at the camp. There were very few who said that they had made the journey before. There were some folks who it was their first journey, but they particularly did not bring, like men would tell me that they did not bring their wife or kids because they wanted to see how difficult it was before having them do that journey. So the idea would be that they were intending to reach the United States, live and work for some amount of time, and then at some point in the future, go back for their family members. And that was interesting. It was also interesting to hear how many people said that they, like I had mentioned in the beginning, that they wished that they had known, that it wasn't what they were expecting. And there is actually an information campaign. I would actually have to look up what the funding organization is, but it's a social media campaign to basically tell the truth about what the journey through the Darién Gap is like, and to discourage migrants from making the trek.
Thank you so much. It was a really, really interesting work.
Okay, I think we're going to have to end it here because I know people have other engagements and classes and so on starting at 1. But maybe we could just do a round of applause for our speaker. It was really wonderful to have you, Dr. Erausquin. And this will be recorded. We'll be putting it up on our Bixby YouTube channel, so you can also alert colleagues that they can see it at a later date. Thank you.